Hello, ladies and gentlemen. Welcome to yet another show from the waiting room. This is Waiting Rooms Trust. My name is Hadassa, your host for today. And it's been a while. I know many things have happened, but here we are. Very happy to be back and coming with the best in town today to discuss issues that affect us directly. So, ladies and gentlemen, get ready and meet our guests for today. Let me allow them to introduce themselves. I don't think I can do this. So, gentleman without a name, can you let the audience know your name?
First, I think.
All right, ladies first. He's being a gentleman.
Cool, thank you. My name is Elsie Wanderer, and I am the founder of the Endometriosis Foundation of Kenya. I'm an endo warrior, so proudly representing the 1 in 10.
Mm-hmm. Please add that you're my friend.
Oh yes, and I'm your friend. We're
Thank you.
BFFs.
Mm-hmm.
Charles Muteshi, gynecologist originally, but endo fertility specialist at Aga Khan Hospital in Nairobi.
Now you know them. Our today's discussion is going to be surrounding waiting, as usual, endometriosis, adenomyosis, infertility just as a whole. So let's get rolling. In case you have any questions, remember you can ask us and we'll probably include it in the next presentation. So that, Tari, the first time I heard of the term endometriosis was when I was told that I had it. And I remember even struggling to read it. I was wondering, endo. Then the other shocker was, Hadassa, you not only have endometriosis but adenomyosis. I'm like, what are these things, Just tell us.
It's very complex medical terms, and because not very many people know about them, you won't really know or have heard about it. Endometriosis is basically a situation where you find the cells that look very similar to those of the womb lining, the womb lining where a period comes from. Mm-hmm. They will be found in places other than the womb lining. So when you find them hovering all over the place, then we will say it's endometriosis. When these cells find themselves in the muscle of the womb itself, then we call it adenomyosis. So basically, it's the same thing, just that where they are placed.
I hope you got that. So just to clarify, endometriosis, is it in or out?
It is outside.
Outside. Adenomyosis?
Within the muscle.
Within the muscles. You got that. So Elsie and I happen to be having the in and the out. But we are still here and laughing. So just to let you know that it's not a death sentence. And let's just learn and see how we can probably handle these conditions and just manage and also recover from them. It's possible to actually heal from some of these conditions. Elsie, how did you find out that you had endometriosis? What were your symptoms like?
So I started menstruating when I was about 13 or so. But then I think when I was about 15, that's when now all hell was breaking loose. And so for me, it was very painful periods. Like my periods would come and I would feel like I was under attack. My body was just in a lot of pain, and especially in the pelvic area. And this resorted to either me being rushed to a doctor to just get an injection, or just staying at home, hugging the hot water bottles, and really just being indisposed. Being indisposed, like it was just impossible for me to do anything. So I was not even participating in school activities. And I remember at that time, that was when the girls in school would say Elsie's feigning her illness because she's trying to get attention, or she wants to get away from, she doesn't want to participate in the activities, or she just wants an excuse to just not do stuff. So yeah, I think by the time, that went on until I was about 26, and I think it kept getting worse. And I think that's when at 26 I was like, I need to find out what this is. But remember, in our community and in society, we've normalized pain, and so for a lot of girls, it's you go through this, it's like it's normal. It's normal. It's normal. Just go through your pain silently. You don't have to make any noise about it or make a fuss about it. And I think that's where now I kind of just put my foot down and I said, look, I need to get some medical expert just looking into this. And then when I went, Charles has really described endometriosis well. I think the easiest way that this guy could describe it for me, because I couldn't, I could hear what he was saying, but I was like, I still don't understand what you're saying. And the easiest way, he just said, okay, fine. The easiest way for me to describe for you what's happening is that your uterus is growing inside out. So that was so funny. So I went around, of course, telling people, oh my God, my uterus is growing inside out. It was so cool. I thought then, because like, at least now I have a reason. Like, I know what's happening. My uterus is growing inside out. But it wasn't the case. So I think for me, yeah. So I think the pain just, and all the time just always having to go for the shots and popping the pills, the painkillers, I think for me was just the way it manifested. And of course, painful bowel movement, I think, was my other, the other flag for me that something wasn't right.
It's interesting. I think we had similar symptoms, because I also went through the same. But one thing that bothered me, every time I informed my parents that I had this weird feeling, when I was taken to the hospital, the first test the doctors carried out was pregnancy test. And I kept telling them, I am not pregnant. I don't even know what sex is. And they insisted, okay, give me the painkillers first, then check that pregnancy. They're like, no, we have to test you first. Why is it that when young girls go through this, they're suspected to be pregnant? Is it related to pregnancy in any way, Dr.?
It's not related to pregnancy. I think it's a judgmental approach to, when you see a patient and you think she's rolling on the floor in pain, might be something she's hiding
Right.
from parents or from someone else. And because everything is around the pelvis, let's make sure she's not pregnant. Of course, we do know one of the pregnancy complications that come with pain is an ectopic pregnancy. So you may come in pain, and you have an ectopic pregnancy, which can be life-threatening. But it's sensible to explain it, that someone understands what you're thinking about.
And also that probably you've carried out an abortion and now it's coming out, and I'm just thinking, no, that's a lie. So I guess what you say is very important. It's important that the patient is given an ear, probably understand before being judged. My old doctor, did you hear that? There's so many themes and so much myth surrounding endometriosis and period pain as a whole. Like Elsie mentioned, we are in a society that normalizes period pain. Like, itaisha too, that is just normal period pains, give it time. But I've learned that endometriosis, or these two conditions, are different. Like, honestly, nowadays I take leave. I take days off completely when I'm on my periods, because I'm tired, and I'm just tired, and the pain and all. And for so long we've been made to believe that there is no solution to it. So maybe just as we address these things, what I'm really waiting for from you, Dr. Rick, at some point to tell us if there is any silver lining. But let me go to Elsie first. I know you are the founder of Endometriosis Foundation of Kenya, doing an amazing work, by the way.
Thank you.
Tell me, I'm sure you've come across so many girls who are going through this condition. What is the youngest person you've dealt with?
I think the youngest I have dealt with, I think she was probably still in high school, but I'm not sure about her age.
Okay.
And, this was through her mother that she reached out. Of course, because it was social. So I'm assuming that she didn't have access to social media. So her mother is the one who contacted me on her behalf. I don't think that, I think we know one for sure that endometriosis starts manifesting the youngest I think should be about 17, and Dr. is here. 15, and Dr. is here. He could correct me because he's the one who sees the patients. Yeah. But I definitely know that based on even just the feedback that I've been getting from the women who participate in the group, that they're as young as even sometimes 12 because they've started their periods. They're in so much pain. I think there's a niece of mine who I also know who's going through this pain, and just no one has an answer for them. So I think we need to probably at this point hand over to Charles to tell us what's the solution for teenage girls.
Yeah, so I think that question is particularly relevant because people thought endometriosis affects grown girls. They're in their 20s, 30s or 40s. And that's part of the socialized normalization of menstrual pain. We have case reports that girls who haven't had a period yet have symptoms of endometriosis. Yeah, there are few, but it just tells you that, endometriosis has to be thought about from a very early age. Currently, I think my youngest patient is 13. And she already has endometriosis confirmed. That public awareness is extremely important.
Is it genetic, Dr.? Someone once mentioned that, like when I suffered this, can you trace back, did your auntie have it to your mother? I'm like, no. In my family, it's just me who has this pain. Is there anything about genetic and endometriosis or adenomyosis?
It's a very complicated link. It's not an inherited condition. So, but when you look at genetics, genetics is not just inheritance alone. But we have certain genes, up to about maybe 30 types of different genes that may put someone at risk of getting endometriosis. But when it comes to these kind of genetic interactions, it's important to know that the genes are there which may put you at risk, but you need something else to trigger the disease process. Yeah, so it's an interaction between either environmental factors, certain things that happen, and of course the manifestation of endometriosis commonly will be pain, and there might be something that triggers pain. It may not just be the endo itself starting pain. You could get, an injury, a urine infection, or an initial trigger for pain, and then, it wakes up this monster.
Charles, you've mentioned something quite powerful, and I would love for you, for the sake of the endo warriors who are out there, who might think that, yes, the endometriosis started, like when I was 35, when I was first diagnosed, but maybe it was just lying dormant there, and then something happened. Do you just mind just elaborating a little bit about that?
The triggers.
Yeah, so especially when it comes to pain, what happens is that you have an acute source of pain, which may or may not be managed well, and then it gets to what we call chronic pain. And in the background of endometriosis, because endometriosis is what we call inflammation, so there's something that is happening causing tissue injury. Even though it is so subtle that when you now, it's like, adding fuel to fire, then the disease just starts to get out of control.
So for the lady who was probably got pregnant and then she gave birth, and then the endometriosis, the pain manifestation began after she gave birth, that explains it. So that's an event.
So there will be certain forms of birth trauma. So, you might have a cesarean section, which is an operation that can trigger pain because you have to heal from that process. You might have pelvic floor damage of some sorts. Even the baby just coming down and stretching things can cause pain on the nerves, which requires a bit of healing. So if that is not well managed, then it evolves into chronic pain, and it makes endometriosis to start showing symptoms. But that's not for everybody, but yeah.
I'm just here wondering, what can be done to avoid such triggers, like, is there anything that can be done?
Yeah, so you possibly wouldn't be going around your businesses saying, I want to make sure that if this happens, but it's basically if you have a bladder infection, a urine infection, have it treated well and fully. Right. Yeah, if you have an injury, acute injuries respond very well to pain medications. And if you notice this pain isn't going away, it will be useful to have it addressed sooner rather than to wait, for months before you present.
Did you catch that? It's important to go for diagnosis. Don't assume your pain. Don't ignore the small signs. Get yourself checked. And her issues may be different from mine. Her symptoms may be different from mine. So it's very important to get yourself checked. And don't take medication because it worked for your friend. I hope you got that. Maybe we can save ourselves from this monster. Dr. Suppose the trigger has happened. Everything has happened. Now I know that I have suffered endometriosis. Please tell us about options in terms of medication available? Because as endo warriors, I believe you've gone through surgeries, Elsie?
Yeah, 4 to date.
4 surgeries today. I've also gone through 4 surgeries. And I kept wondering, must we go through surgery after surgery every so often to try and deal with this?
Right.
Can it be done once, right, and sort it out? Is it possible? Maybe address endometriosis and then the solution for adenomyosis. Then I'll come back to you for your experience.
Yeah, so I think where pain is a predominant symptom, we need to cut the cycle of the pain. Whether you use medications, whether you approach it surgically, or using other, alternative methods, because perpetuating pain just makes things worse. If we use medications, then you want to use that as belts and braces, so you kind of a backup of sorts, that I have kept my pain at bay and I want to be fully functional. So you get your body back into functionality. You can stretch, you can do things, and then it learns again that I can do things without having to feel pain. And your brain is retaught, you kind of relearning. If surgery is the way to go, then you make sure that the surgery itself is not going to cause more pain, because surgical trauma is painful. Yeah, so healing from the surgery should be managed very well for the acute pain. But secondly, it should be comprehensive and complete, so that you're not leaving behind disease that will have to start manifesting itself once you've gone through the acute phase. You may notice those who are struggling to maybe recover very well from an original operation may actually be putting themselves at risk of developing ongoing pain. Now, not everybody is able to, completely and comprehensively remove the disease process of endometriosis, which is understandable. But if you think you are not able to completely remove the disease, then it's better not to touch it.
Right.
Leave it alone so that somebody else can come in. Because once you start fiddling, you scratch it around, then you make it worse. You're kind of working this thing, which is in some semi-dormant state, even though it has symptoms, but you're just making it worse by scratching on it and not taking it away.
So was yours scratched, Elsie? Because I'm wondering why you had to go in. Speak for me today. Why did you have to go 4 times?
I feel upset, whenever Charles keeps talking about the scratching thing, because I can't relate. Yeah. Because I saw the surgery, like if anyone who goes in laparoscopically, you're given the footage of like the procedure and what they did. And I really believe they scratched. I think I saw burning, I saw fire, saw smoke, stuff like that. Charles, probably you'll tell us what all those are, and if it's necessary. So anyway, so mine was because they were dealing with a lot of cysts and adhesion, so they were cutting all of that, and then burning. So I saw that, but I never saw. I didn't see anyone excising, which probably let Charles actually give us the definition of the difference between excising and ablation, because I think that's what the common treatment that a lot of women have gone through in Kenya, and that's why it recurs. So for me, I think my first, second, and probably third surgeries were that, but my 4th surgery was the gold one.
It wasn't scratched.
It wasn't scratched.
It was chopped, in other words.
Let me not even just blow his trumpet. He's right here. He'll probably talk about it. And by the way, for real, it's not even about like even just giving Charles the accolades and stuff like that. But it's actually recognizing the difference, like how my body feels post surgery. Is very. I cannot compare it to the other the surgeries that I went through, and again, the conditions that we suffer are not simple. They're complex, and how they manifest in our body, even just the lesions, being able to see them. If you don't have the eye, if you don't have a trained eye to be able to identify it, then it's easy for you to miss it and even just leave it lying dormant. That's why I think my endo just kept recurring. And the periods between all the surgeries just kept shortening and shortening. And I think it is a result of that, being scratched. And then, it just kept getting worse. And I think Charles, I think sometimes when he tells me about what he found in there, I just black it out because I'm just like, I don't even want to know what you found. But he talks about this frozen pelvis, like that was, everything was meshed up together. And that actually explains it, because there were times I could not move. I could feel I would turn, I would feel like something is moving with me. But that's something that was dealt with. And of course, he's taken care of me. He's taken care of me very well. And even before the surgery, I appreciate the fact that we walked, even in the pain. Much as I wanted the pain to go away, we did, we had different interventions. So, we had some hormone therapy that at least we could try and say, okay, so if we suppress this and, leave the other or whatever it was he was doing, do we see a difference? So that surgery is not like the first and the only, because that's what I hear also you're asking, is it the only way out for us? And I think there should be some, the girls should get options. And I know that girls are scared, because every time they're going in for surgery, they're like, I've never gone in for surgery, I'm nervous, I'm afraid. No one should ever be happy and save us who we're always taking photos so that, of course we're raising awareness, but no one is ever excited. No one is ever really, thrilled that I'm going under general anesthesia.
It's difficult.
And, so even the body just recovering and everything, it's hard. But I think for me, it's just understanding, okay, what should be, and maybe I feel like I've taken over, but I think I can ask questions. What should be the path, before surgery? Is that the only, and should it be surgery first, or are there other interventions that can happen before surgery?
So I guess you'll be addressing that.
Yeah, I'll come to that.
Yeah, it's like hormonal therapy. Yeah. Before he addresses that, so that comes next, I want to understand, you talked about frozen pelvis. Sorry, what is it? Frozen what?
So it's not really about temperature. So you don't go in with a thermometer and say, oh yeah, it's ice cold in my pelvis. No, basically the organs within the pelvis, or the reproductive system inside, are designed in such a way that they freely glide over each other. You've got your bowels moving around. You have the womb that has the tubes that's coming off it, and there are ovaries there. So when an egg drops, the tube picks it up. But when you have a severe endometriosis, everything is stuck together. You can't make head or tail. Yeah. So that's what we call frozen pelvis.
And maybe to just clarify still or explain further, let me use my example. The first 3 surgeries I had, the first 2 actually, my endometriosis was in the ovaries. But by the time I was going for the 4th one, my pelvis was actually frozen, because the intestines attached to the tubes, attached to the ovaries, attached to everything in the rectal area and all that. Is it possible to avoid that? You talked about if we get it right the first time, it shouldn't recur or grow.
Yeah.
But I've had this explanation, maybe it's a myth, I don't know, you'll explain, that if it's not handled well the first time, and if it was supposed just in the ovaries, it can spread to these other areas. Could that have happened to me, or how does this work?
So it's not that simple, but what we don't always realize is that the presence of endometriosis on the ovary means there is endometriosis in other places. But because the cyst is appearing as an easy target, then you go for it. You remove the cyst, but you leave the other disease behind.
So it's not like busting a bubble, and then these things.
Yeah, so it's not really spreading around. You already have,
right.
what we call deep endometriosis or deep infiltrating endometriosis. So whenever you have a cyst, and you have to be very careful that you're not just going to have a cyst from the ovary removed. 50% of the times there will be concurrent severe disease. Now, the problem is, apart from it being a frozen pelvis, it is what we call deep endometriosis, which would mean that the disease is far deeper in the tissues than you would easily see it. So you have to go feeling for it. You have to know what you're looking for.
Elsie mentioned hormonal therapy. I believe we've both gone through that. And as much as I know it's one of the ways of dealing with this that the doctor is going to address, I really don't like it, Doctor, from a personal view, because the things it has done to my bones, I can't explain. So maybe just help us out. Explain, help me understand if this is a solution that we can't avoid. And if we have to go for it, is there anything we can do to protect the other parts of our bodies, our bones specifically, our kidneys and every other thing? And those horrible menopause symptoms, is there anything that can be done?
Yeah, so hormonal therapy is actually a very broad term, and it may not mean what is actually done. So when you say hormonal therapy, ideally you're talking about a combination of estrogen, progesterone, or the pill, for example. If you look at the general population, people who are using the pill for contraception, there will be thousands and thousands of them. But a choice to use the pill, it's usually arrived at after you have looked at all your options and you feel this is the most suitable thing for me. And girls who are using the pill for contraception will have worked out and know that, yeah, I think this is the best, and they would take the pill for many years. Problem with endometriosis is that you're told you have endometriosis, take this, and you don't have that chance to kind of weigh and, look through. Yeah, and you are already horrified by the diagnosis. Right. And you are always looking out for what else is going to be happening. And of course, they don't come without side effects. Yeah. And they also act by only temporizing the symptoms. So if I give you the pill, you may feel okay. When you stop the pill, the pain comes back. So most people don't understand that I'm taking this to suppress the disease. They are thinking that I've been giving the pill to take away the condition. We also have suppression of your hormones, which is given a wrong terminology of hormonal therapy. So when we suppress your hormones to go into what we call medical menopause, we're just withdrawing all the hormones from your ovary. And that would come with menopause symptoms. And that's one of the treatments that is dreaded, because when you start having hot flashes, when you lack enough estrogen and you don't build enough bone strength, then you have all these other effects. And it also affects your mental health, because if you suddenly withdraw your hormones, and most of you will relate if you've got mothers or grandmothers who've gone through the menopause, as you watch them, they suddenly become very irritable, and they're forgetful, and they have all these other things. And that's just because of lack of that hormone called estrogen. Yeah, so you have to discuss that with your doctor. But be aware that there is something you can be given to prevent those symptoms. So you can't just go through that phase of 3-6 months with complete suppression without any replacement of your hormones.
I think there's a lot of questions around, these are the effects and these are the symptoms of the suppression because of, and they name the drugs, and you can actually tell, yes, that is actually, some of the effects that, I experienced. But I think you're raising something very powerful, saying, and I think it's one of the things which I try to encourage the girls, speak to your doctor about the symptoms that you're experiencing, and the side effects that you're experiencing, because if they're unbearable, certainly there's no way the doctor should continue allowing you to bear that just for the sake of this one thing. I think there should be like a package that they offer you to say, okay, fine, you might experience this is what you need to supplement, like for bone density, calcium. How do you find natural sources so that you're also not overloading with the wrong dosage of calcium, because it's all there. It's omega-3, you hear about all these things that you have to do. We've heard about people coming to us and saying that these natural options will treat endometriosis, and I think
and people lie a lot about that.
They do.
Like, really
And
take
taking
advantage of
vulnerable
people. Yeah, it's very sad about
women.
Now, I wanted to ask you, Dr. You've talked about all these things that the therapy can do or can cause side effects. Please also address sexual issues. I know there are married people who suffer endometriosis, and once they are given this, we've had cases in our group where the husband says, my wife is no longer interested in sex and all this. Could it be an issue with the medication before we come to the painful sexual intercourse that happens before treatment? Please go ahead.
Yeah, there's possibility, and of course, different meds are used. So, conventionally, we used something like Depo. Depo is a common contraceptive injection, and it could also suppress endometriosis. But one of the biggest side effects with it is lost sexual drive, causing vaginal dryness and just lack of interest. You wouldn't want to be finding yourself in that place where you've got a partner and you say, well, I'm on this injection, and you excuse me for the next 3 months. They will.
6 months at most.
They'll be having different thoughts in their head. But the key to managing endometriosis is personalized care, because not everybody will have the same side effects, and you have to be ready to kind of walk a little bit, diarize the symptoms, and say, if this is happening, try to relate it with what you feel and the disease process. But also remember that you have endometriosis, but you are human, so you could have something else. So not everything that you have is because of the medication or the endometriosis. You could easily overlook another diagnosis, simply thinking that, I'm taking this, is causing me these symptoms. So make sure that you are able to describe them, ask your doctor whether they think it's because of the medication, whether it could be something else, because once you have endometriosis, it does not mean you can't have anything else.
I think, gentlemen, did you hear that? And our doctors and the couples out there, if you suffer from endometriosis, ask about the symptoms. If you're experiencing all this low sexual drive and all, your doctor would actually be able to advise you on what can be done, so that it's not a 6 months waiting period. Dr. We talked about hormonal therapy. Now, hit us with the surgery option that you think would work best. Elsie mentioned that when she watches her videos post-surgical, she sees smoke and things burning. We should watch those videos together. And she asked me, what is that he's cutting? What is he cutting? Dr. Is there an option in terms of surgery? What would you advise?
Yeah, so just like anything else, I think the surgery for endometriosis has undergone evolution. And part of it is because we didn't actually know anything about endometriosis before. And we didn't have laparoscopy. All the colleagues would open up and find what we described as a frozen pelvis and close, because there's nothing they can do. And then brave people, probably in the late 70s, 80s, started operating, but open surgery. And they would go in and, remove as much endometriosis as possible. But because it's, it's a very blunt surgery, you can't really cut everything. So they would only do what we would describe as adhesiolysis, meaning they release the scar tissue, but the disease process would be present. Laparoscopy kind of revolutionized the whole approach to managing surgery in endometriosis. But laparoscopy has a learning curve. So it's a fantastic piece of equipment. You put your telescope and you can see everything clearly. But then you suddenly have to use instruments that are very delicate, kind of what kids do when they're playing on their PS4s and stuff. So you need that learning curve. And if you haven't learned it, you may not be able to do it. So the safest thing then was, I can see lesions of endometriosis, I can buzz it. So you kind of, you burn it away. And because we didn't think that it was far deeper than what we can see, then you didn't actually treat it. But once we followed up patients and realized, yeah, that is not effective treatment, and we learned that we can do better with our instruments. You know, your dexterity and your hand-eye coordination improved. You know, the cameras we use and the telescopes have become more powerful. Now we can operate better. So we know that using these delicate instruments, you can go in and cut the endometriosis away, what we call excision surgery. But remember, as we said before, endometriosis lives around the bowel, it lives around the ureter, it lives around the bladder, might be on your nerves and blood vessels. So not everybody can just go in and cut, because you'll be cutting these normal tissues. So it has to be done in a very careful manner.
I think that's the silver lining right there. There's actually a solution. There's actually something that can improve your quality of life and all when it comes to endometriosis. And you just mentioned it, it's excision. And Dr. Muteshi actually is an excision specialist. So you can actually reach out to him for help. That is endometriosis. What about adenomyosis? Can we also have the same approach, or what can be done about it?
Yeah, so adenomyosis, as we said before, is when you find these cells within the muscle of the womb. So they are nested in the muscle of the womb. What is very common out there is something called fibroids. So most will have heard about fibroids, which is just cells of smooth muscle of the womb that multiply on themselves, and they form small little balls. So for those ones, you can go in and remove. We call it a myomectomy. But for adenomyosis, it kind of spreads and embeds within the muscle, even though occasionally it may look like a fibroid, but it's actually intertwined within the muscle. Traditionally, we used to think only women who have had children can be diagnosed with adenomyosis. And that mistake came from the fact that we would only remove a uterus in a woman who says, I'm done with childbearing. So then when you take that uterus to the pathologist to look, they say, well, the uterus has adenomyosis. And disproportionately, women who had hysterectomy, which is an operation to remove the uterus, would have had babies. Those who didn't have babies were less likely to have a hysterectomy. Yeah, so a lot of people think, and girls will tell you, I went to my doctor and he said you can't have adenomyosis because you have not had a baby.
Right, okay.
And also, traditionally, you would hear that, the only treatment to adenomyosis is hysterectomy, because it comes from that traditional thinking that we only removed uteruses because they were done doing their job. The difficulty now comes in, how can we remove adenomyosis and leave the womb behind without having to damage it so much? Yeah, so it's a little more complicated, and there is some emerging evidence that you possibly, especially if it's localized, if it's only in a small area, maybe you can wedge it out and maybe stitch back, but the evidence that it's effective is lacking. So you have to really be very careful if you're going to theater because you want to cut it away. So it is amenable to medical treatment much more than surgical. Yeah, so you may manage it more with using the pill or hormonal treatment. And there's now a coil called Mirena, which is a coil that you can place in the womb. It has progesterone. So it seeps through the womb very slowly every day, and it's very, very effective in managing adenomyosis. But of course, you can't use a contraceptive method if you're trying to get pregnant. So if you want to get a baby, then you want to have a coil. So it kind of, you have to really balance.
At least, okay, there's the difficult side in terms of things that are happening in our bodies, but there's hope. That's the bit I like about such conversations. Like, yeah, people look at me and you and other Endo warriors and wonder, where do we still get the strength to smile? How do we still go online and laugh and say, today I did this, we work out, and you're not feeling pain when you work out and stuff like that. How do you just keep yourself sane, Elsie?
So
maybe just look straight to the camera. I want them to see your facial expression.
It's interesting because, when I'm asked what I do, this is usually funny, but I do it. So there's a game on my phone that I like to play with. So that's the thing that takes me out, like, and just helps me just release all the stress. But I also read quite a bit. I started exercising. I started cycling. But of course that was interrupted by these other surgeries and procedures that I had to go for. Yeah. But I'm looking forward to that. But the reason also why I keep waking up every day is because I keep saying I want to make sure that by the time I leave this earth, I have done my part in making sure that girls have got equal access to care that we did not have. And I think that's what you and I are passionate about. So I decided to wear this, I decided to become the face of endometriosis for the many girls who continue to suffer in silence, because it's needed. There's quite a bit of fights that we have to fight for this, ending the stigma, even in the workplace, in healthcare, like in insurance. I think that's just like a very hot topic, which I think we need like another session. But those are the things. So we must continue fighting. We can't sit back and just say, this is normal, and this is us. No. We are more than our conditions. I am a CEO of another organization which I lead. So I wear multiple hats. I do so many things. I can't stop just because of this endometriosis. So I don't allow it to manage me. I manage it. And I think I work very closely with Charles. And I ask him, I think that's what I appreciate about the relationship that I have with him, is that I can ask him anything, including my myths, even when he knows that he has told me and warned me, do not Google. I will Google and then I will ask him. But I appreciate that his door is always open to me. Like the other day, I think I was thinking and imagining that I had endometriosis in the ureter because of the kidney issue. So I told him, I think it is. And he's like, no, Elsie. So I was like, okay, let's at least rule everything out. But I think that's, for me, what I'm saying is just, I think have a doctor that you can actually talk to.
Do you cry, Elsie?
I do. Mm-hmm. There are days I've actually cried with Charles on the phone. I do cry. Yeah. The other day I cried like a baby, because I think, I think that was like the fifth and the sixth surgery that I was going for. So my body is already tired, I'm exhausted. I'm one human being, and for this body to have to go through all that it's going, it's not easy. And then the financial burden of the procedures.
Yeah, it's just not covered.
It's not. I mean, I'd bust all my inpatient and outpatient covers. So there are days, and you have to allow yourself to cry. Of course, you cry pretty,
Yeah, you have to maintain.
You maintain beautiful. But no, you do the ugly cry. You must, yeah.
So basically what I'm asking that is, there are low days. We have our low days. But it doesn't mean that is the end of life. I like it that we give hope to everyone who's gone through this, or who's probably battling with the decision to see a doctor, to see a specialist, for fear of the unknown. It's easier managing something that you know. I know very well we have different triggers. I know gluten is one huge trigger for me. I take it now and I'm bloated. I just realized I didn't know. So, and I realized working out helps me. Walking helps me a lot. Reading or dancing helps me release stress. For Elsie, it's her game or the many things she does. Yeah. And see, she still goes to work. So it's actually possible to live a life still as an endo warrior, but manage and go to work and do all these things, but have a support system. Endometriosis Foundation of Kenya is here, and it's open to ladies and sometimes even gentlemen are in the group. Yeah. Waiting Rooms Trust is available. We focus on different ailments, not specifically endometriosis, but others, and also infertility as a whole. Dr. Muteshi is here. He's actually on social media too, so you can just slide into his inbox and disturb him Don't say any mean words. Just focus on the health and all. So maybe just to wrap it up, let us talk about, okay, we've discussed excision surgery. And I know many endo warriors or adenomyosis warriors battle with infertility. What would you advise? And then when you're done with that, kindly give us your parting shot in terms of hope to that person who's struggling with this condition.
I think we've come a long way, but the road ahead is still longer. There is good evidence emerging currently, particularly for endometriosis, that if you do a good excision procedure and there are no other reasons why a couple may not get pregnant, they're more likely to be pregnant in the next 18 to 36 months. So, if you read 5-10 years ago, literature would say if you have severe endometriosis, then you need IVF straight on. And of course, in vitro fertilization or IVF is not available or accessible to everyone.
True.
Yeah, but the fact that we can now do more extensive surgeries and restore what we call pelvic anatomy and give you a chance to get pregnant, then we're seeing girls getting pregnant. I don't think I've kept recent statistics, but I've got a few people who have gone through surgery with me in the last couple of years, and they call me and say, well, I'm pregnant. Most recent was a girl who wasn't planning, and she called and says, I think I missed my period. I said, have you done a test? She said, it's positive. What do I do? And I said, well, I'm also a fertility doctor, so you can't ask me what do I do. So, yeah, so that's something that is available now. There are times when you may find a combination of factors, and surgery alone may not be effective, and then you fall back to me again, and we talk about in vitro fertilization or IVF. And both endometriosis and fertility are customized. We look at you and say, yeah, this is what may suit you best. It may not be 100% effective in getting a baby, but you also reduce what you call treatment burden. Yeah, so we don't just hammer you with all manner of things, saying, yeah, we're going to make you pregnant, and then you don't get pregnant, and we leave you deflated. We make sure that we walk with you through that journey. Yeah. I think my parting shot generally is usually not what I'm doing. It's to make sure the girls are empowered, and it's always very helpful that when a doctor tells you, this is what I think you've got, take time to understand what it is and what options there are to manage that condition. There is nothing wrong to seek a second opinion or to ask your doctor, let me think over it and come back so that we can discuss more. Yeah, because what breaks my heart a lot of times is when you walk into my office or you find a girl went to clinic on Monday and they're in theater on Wednesday.
Right.
I just don't understand how that processing happens. And 2 or 3 weeks later, they come to me and say, I was diagnosed with endometriosis. And I asked, what was the planned surgery? Oh, I didn't know. What stage of endo do you think you have? Oh, I don't know. So, you're rushed through without understanding what's happening. It's distressing enough to be told I've got endometriosis, but just take your time to understand what's happening and what options there are. And as you've said, there are support groups. You can always ask someone else, if you have been diagnosed with endometriosis, what does it mean? What do I need to do?
True. Well, I like that. There's hope, there are solutions, and I think what I want to rub in is, once you get your diagnosis, take your time to process, seek a second or a third opinion, ask your doctor about the plan. Don't just rush into surgery, like some of us did. Elsie, what's your parting shot?
I think I would like to celebrate the fact that the landscape has changed. What like when I remember the first time I started talking about endometriosis, which was in 2015, I mean, now, you're interviewing, TV stations are interviewing. I think the month of March is usually like flooded. We have got so many interview requests. And for me, that is a sign of the environment is changing. People are becoming more, they're accommodating this conversation. And so I think for me, the encouragement is to other ladies, don't hide in the dark with this condition. I think the only way we can actually get the attention, and this disease can certainly get the attention that it deserves, not only from the public, but also from the medical experts, is when people actually begin to make noise about it. And the only way that we can do that is by sharing our stories. So don't shy away. Part of us ending the stigma also involves us talking about it so that we show and present that we're actually normal people.
Yeah.
We're actually people who are going about our lives. And, that, we shouldn't, by any chance, we shouldn't be missed out on any opportunities to advance our careers just because we're ailing. Mm-hmm. Our pain is not something we sat down and we cooked and we drank and then so that we could actually be where we are. It's something, like Charles has been talking about this whole show, is that it's complex. It's difficult to even understand. And right now there are people working. I'd like to also celebrate the fact that there are scientists locally who are doing so much work. I mean, like, let me tell you guys something. I had to read up to understand the condition, to understand like who is available even in our own country. Yeah. People who've received accolades and awards and recognitions for some of the work that they are doing. The only way that those guys will be made visible is by us now coming up and then saying, yes, we do need this treatment. So for me, I think it's just to celebrate the fact that thank you for the girls who continue to talk about endometriosis. Thank you for having us here to be able to talk and share with the broader community. There's nothing wrong with us. We just have a very complex condition. So I think that's the only thing that, and encourage the other girls, like, yeah, please come out and speak about it. There's no shame. And thank you also for just ending the stigma around fertility and just the fact that because we've been impacted this way, we are now, categorized as these people. But thank you for giving us a platform and a place for us to even be able to be part of a community and share our stories. Thank you.
You are most welcome. And just remember that period pain is not normal, in addition to what Dr. and Elsie have said. Period pain is not normal. Get help. There's this tendency of mothers just giving out painkillers to the girls when they have pain. Please, get yourself checked. You don't want to end up with several surgeries like Elsie and I have. Maybe it's something that can be sorted now. Don't ignore that small sign. Period pain is not normal, and endometriosis can be sorted out. So there is hope. Don't give up if you've gotten a fresh diagnosis for this. Keep your head up, keep the faith, reach out for help. And from us at Waiting Homes Trust, thank you so much for joining the show. Until next time, goodbye.